All right. Hi, everyone. Thanks for coming tonight or joining us on the webinar. We have Judy Daniel here tonight, who is with the topic of home health. So she's the Director of Therapy for HCR Home Care and the Education Chair for the APTA Home Health section. And before we get started, just a couple of announcements. The Central District will have their elections next month at our March meeting. So if any of you are interested, there will be probably an email soon with upcoming, or for the positions that will be open, and also for the Delegate Assembly, which is in the end of April. I think we still have a couple of spots left, so there will probably be another email about that to fill those seats soon. So I'll turn this over to Judy.
All right, thank you, everybody. Can the folks in the room hear me all right? Okay, great. Thanks for Mike Tisby. He was my contact. Where'd you go? So he's my contact. He and I met probably 2 years ago about a bundled care project here in the Syracuse region. So thanks, Mike, and also thanks to Amy for getting me set up and being such a good hostess. So, okay. Our down arrows aren't working. All right, so we'll do this manually. So a little bit about HCR Home Care. Full disclosure, we are a home care company that's new to the Syracuse area. As you can see, the New York State map, we still are operational in the Rochester, Monroe County area for over 35 years. We have lots of accolades being a high quality, ethical company, and we've recently expanded actually over the last 8 or 9 years, in particular Onondaga, which is Syracuse, and north, contiguous all the way to the North Country up by Plattsburgh. So we are operational in 22 counties in New York State. I live in Rochester, but again, we have offices here in Onondaga, and I have 38 therapy staff in this region of the orange region on the map. So I'm here pretty routinely to do on-site co-visits with our therapy team members, annual reviews, competency checks, that kind of thing. So I'm very happy to be here. So objectives for tonight, I won't go through these, but this is a very quick overview of home health. This lecture can be sometimes as long as 4 to 6 hours. We're just going to put a lot of information in 1 hour. And then if there's interest, I can certainly come back. But again, we're going to look at some special tests. What are the billing mechanisms? What's a typical patient look like, and where do they come from? How does a referral start in home care? Boy, this is a quiet group. So I don't know, has the rain dampened you down? I hear that there's a big test or a couple of tests this week, so maybe that's it. So just to start with, home health is a very small segment of the healthcare arena. If you look at this, what is it, 3%? So this is Medicare dollars. So people who are over 65 who are Medicare eligible, home health is only 3% of their care, or 3% of the annual budget of Medicare, which is really a very small segment. But again, it's really growing, and you can probably imagine why it's going to grow, and it's because of the baby boom. This is some information from the PT in Motion, which is a journal that you might receive if you're an APTA member. But again, it's projected home health section, or the home health sector of healthcare is really projected to boom. So if you like, in general, geriatric patients, some pediatrics, kind of being very autonomous, you have to think kind of holistically, and we'll talk about what that means. Home health might be a good opportunity for you. And I understand from Amy, or some people are getting ready for their home health affiliation. So if you have any questions, now's a good time. Again, the baby boom. So this the anticipated growth is between 2010 and 2020. It's the fastest health job growth arena in the healthcare sector. Nationally, the demand for PTs is 39% and 46% for PTAs. Jennifer, who's a PTA here in the audience, she and I were talking about the role of the PTA in home health, and I think sometimes the PTA role is being squeezed out. Actually, I'm a PTA. I was a PTA first and then went to Nazareth College in Rochester. I keep that license. I tell my boss, 2 bad days in a row, and I'm going back to be a PTA. So let's talk about home health, the physical therapist in home health. So we have lots of rules surrounding home care. Is there a way that we can move this caption up top? kind of blocking that? Okay, well, don't worry about it because I know the presentation pretty well. So there are federal and state mandates that surround home health care. The first is a federal, it's called the Conditions of Participation. Basically, it's the benefit manual that says, you know, like when your parents get there every year, you get your insurance policy and it says what you're eligible for, 20% copayment on prosthetics. If you need, you know, dental care, you have to pay this much. That's what this, the patient policy manual is about. And basically, the basic rules are the patient has to be homebound, so they can't readily go out to an outpatient physical therapy clinic. They have to require skilled service. So it takes the licensure, the skill of a physical therapist, occupational therapist, speech language pathologist, or registered nurse. And then we have to have a physician who's willing to sign orders because we develop the care plan, but the physician has to agree to it. And then the care has to be reasonable and necessary. So that means, you know, am I going to use a tilt table in home care? Probably not, because that, you know, that would be a real outlier kind of a treatment or modality to apply in a home care setting. The care has to be intermittent. So we are not, we might be a 24/7 agency, but we're not responsible for the patient 24 hours a day. So the patient has to be reasonably safe for us to step out of the home and let them, you know, manage themselves. And that's challenging. So we have to, when we go in to begin our episode of care, it's called a start of care, we do all sorts of assessments to see, is that patient safe enough for us to step away? And then, of course, they have to have a unique and individualized care plan. So how do we get paid? So when I say we, I mean any home care agency, not just HCR Home Care. So Medicare started this process called a prospective payment system. So every home care company is given a lump sum of money for taking care of that patient in every aspect of home care for 60 days. How do they figure out how much to pay that company? Is either the nurse or the therapist, the clinician who does that start of care assessment in the home, determines or does what's called an OASIS set. So it's outcomes assessment information set. So it's information about their mobility, their medications, their vision, their environment. And then there's this huge calculation that really nobody can game. It's a very convoluted compilation of figures. And they figure out what the payment is for taking care of that patient for 60 days. So it's good for a home care agency to be, you know, to have the gamut of all the disciplines that are needed, but also to be prudent with their visits, because if you're giving, you know, home health aid visits 3 times a week for 2 hours, you're paying that employee to do all that work, but you want to maybe start the care plan with that and then wean the patient away from some of the services. So we'll talk about front loading a care plan or you know, visiting at a higher frequency toward the beginning and then ratcheting down your visit frequency per week as the patient gets better and more stable. For people who have Medicare, home health is covered 100%. Some of the Medicare Advantage programs like Fidelis or Excelis Blue Cross Blue Shield, they are beginning to have a co-payment, like a $20 per visit. So, you know, I'm sure you're seeing in some of your affiliations and some of your care settings that co-payments are just a part of healthcare right now. As far when a patient has Medicaid as a payer, that again is episodic. So again, we get a lump sum for taking care of the patient for a certain period of time. But in New York State, just last year alone, we had 13% reduction. So we're still providing the same amount of care, but a 13% cut in the reimbursement that Medicare is giving to home care agencies for a patient with Medicaid. Then there's the managed care. So those are fee for service, like the no fault, the workman's comp, some, you know, Geico, you know, the MBA accident. Some of those are definitely managed, but they are pay per visit. So home care can happen as long as you're in the patient's home. Now, you can walk around on the sidewalk, that kind of thing, but if a patient lives on a houseboat, if a patient lives in a mobile home or a trailer, actually we've recently seen in this region patients coming from other regions of New York State to come to a destination hospital like Crouse to have a joint replacement, and they stay in like an extended stay America or something like that. So they live in a hotel that's okay. As long as they have a payer that will reimburse them for their care in this county or in this region, that's A-okay, because at that point that we're providing home care, that's their home. Just interesting. Okay, so where does a home care agency get their referrals? A lot of them, most of them are from the hospital, either people who are having elective joint replacement surgery, for example, then also the general medical patient, a patient who's had pneumonia or debility or a fall, multiple sclerosis exacerbation, something like that. Congestive heart failure and pneumonia are two in particular, and then deconditioning associated with that. We also get referrals from our skilled nursing facilities or assisted living facilities. So oftentimes a patient will go have a joint replacement. Maybe they live alone. They'll go live in Elderwood with, under Mike's care for a little bit until they really get better able to take care of themselves, and then they return home. So sometimes we get referrals from short-term rehab, and then also from the direct care physician office itself. So a patient might be brought into an office, maybe with an adult child is now wheeling her mom into a doctor's office because she's had a fall. So home care is certainly is appropriate if the patient can't readily access an outpatient physical therapy clinic. So what's a certified home health agency? So that's in order to bill Medicare and Medicaid and some Medicare Advantage programs, you have to be a certified home health agency. So you have to have an interdisciplinary team to manage the patient. So that means nursing, PT, OT, and speech. We have to have medical social worker, registered dietitians, home health aides, because the New York State audits us on a pretty routine basis. And how well your audit goes determines when the state will be back to audit once more. So it's called a CHA, a Certified Home Health Agency. So there are also different types of home health structures. There's a certified that we just talked about. We're billing CMS, or CMS is an oversight entity for us. Then there's also licensed. So you'll see in the communities like Caring for Mom, there are agencies who are strictly private pay. So you can call and make an appointment with a care manager, and then they'll set up like intermittent PCA, personal care assistants, or home health aides under a private pay kind of contract. Then there's, within those two types of agencies, there's for-profit and not-for-profit. Not-for-profit are oftentimes affiliated with a hospital or some sort of church-related home affiliation. And then there's also for-profit, and that's what HCR is. We are a for-profit entity. The woman who started HCR 37 years ago, Louise Warner, was a businesswoman in Rochester. Her mom needed home care, and she was dissatisfied with what was out there, so she started her own home care agency, and it's grown to over 780 people. It's kind of cool. Then oftentimes there's a hospital-based CHA, or Certified Home Health Agency. And I think like does St. Camillus have a hospital? No? St. Joe's. Okay, so that's right. So St. Joe's has a hospital and a home care company that is they're eligible to provide care in Onondaga, Cortland, some other counties. So who are the CHA patients and certified home health patients? Some are pediatric, and those are really the medically unstable children. Sometimes if a child is in a motor vehicle accident, has fractures, and really can't get on the bus or go and attend classes in a normal school, home health will be a part of their care plan while they're healing. Also, if you have children who are on ventilators, pediatric, even infants who are, have pretty significant impairments, neurological impairments, home health can provide care for the children who are too sick to attend public school. Primarily, it's enrolled adults and seniors, people over 55 and 65 are really the main bread and butter of any home care agency. Again, if a person becomes acutely sick and then has some medical need in the home and can't readily get out to physician's appointments or something like that, or they, that maybe they've been in short-term rehab and then are returning home but still aren't quite 100% back to their prior level of function. And again, in those adult acute patients, the home care agency has to determine that the patient's going to get better. It has to be restorative in most cases. Then there's long-term care, and those tend to be Medicaid patients. low-income patients with chronic diseases, like let's say they have, multiple sclerosis. They have a functional debility, can't always get outside of, out of their home to seek medical equipment or medical attention. So they might have a nurse come in once a week to pre-fill their SETI set because their medication, like you've seen those pill boxes, a nurse might come in and fill those out according to how the physician is prescribing those medications to assure that the patient is compliant. It keeps the patient out of the hospital. So it's a really low burden on the Medicaid system to keep that patient compliant and adherent to their medication regimen. And then hospice. So people have an idea about what hospice is. It's end-of-life care. Not all agencies have that. But then there's also palliative care, which is kind of a step. It can be considered a precursor before hospice. And so that's for patients who are terminally ill or critically ill and probably don't want to go the restorative road, don't want to necessarily work to get better, but they want to manage their symptoms, their shortness of breath, their pain. So sometimes many agencies in CHAs have palliative care programs, but that is different than hospice. So typical diagnoses that we see in home health, joint replacement surgery, like I spoke to about before, also people with fractures, so those are some orthopedic diagnoses that we might see. Neurologic patients with stroke, Parkinson's, ALS, or even paralysis like spinal cord injury, those folks that, shortly after their injury do need to come home, and that's oftentimes home care is ordered at that point as well. Cardiopulmonary, I mentioned before, CHF and COPD are very routine diagnoses in the elderly that we see in home care. And then the general medical patient who's had a fall, the frail elderly, and patients who've been had an extended acute care episode, like been in the hospital for a very long time, that transition to home, a CHA episode is also very beneficial. So changes in home health. So I've been in home health 20 years. I really can't believe it. But again, I practiced as a PTA for a while. And then while I was going to school at Nazareth to get my master's degree, I worked part-time as a PTA in home health. So even in the 20 years that I've been in home health, I've seen a lot of changes. So we're beginning to have some new benchmarks. A big one is ACH, which is acute care hospitalization. So what's happening is that home care agencies are being graded on their ability to keep a patient who was in the hospital, to keep them out of the hospital for a period of 30 days, and then again at 60 days. So the home care agencies who best do that, those hospitals are going to partner with those home care agencies. Because what's so big about being back in the hospital for the same diagnosis? It costs a lot of money. And actually, hospitals may not be reimbursed for that second hospitalization if it's the same thing, because CMS, Medicare, who's paying for that care, is saying, maybe you discharged that patient too early. We're not going to pay you for it. So oftentimes we'll see patients who come home very sick. We begin an episode of home care and they bounce right back to the hospital, but the hospital doesn't admit them. They might keep them in the hallway and under observation for a couple of days until the patient's stable enough to get home. Lots of different scenarios that we're seeing, and I see Mike back in the back nodding his head. So he's living that dream too. So also there's these HCAHPS, which is the Home Health Consumer Assessment of Healthcare Providers and Systems. So this is a survey that patients are being sent to their home after an episode of home care that grades has the patient or their family member or somebody who's associated with the care of the care of that patient fills the survey out and sends it back to CMS. CMS, Centers for Medicare and Medicaid, are rank ordering home care agencies on how their patient satisfaction is. So some of the questions are, did your home care team treat you gently? So guess what? When I'm treating a home care patient, even who's at a knee replacement, I'm going to use that language so that if that patient gets that survey, they're going to say, yeah, I guess Judy didn't hurt me too badly. A lot of the questions about medication, did they talk to you about changes in your medication or any or about your adherence to your medication care plan? Interesting though, my mom is in her 90s. She just got one from her primary care physician. It wasn't from her primary care physician, but it was about an encounter that she had with her PCP about did the doctor take the time to listen to you, to listen to your concerns? Did he prescribe you medications and explain what they were for? So this is it's soon to be rolled out in lots of different care settings. But again, it's to rank order providers so that CMS eventually, instead of going for this lump sum to take care of a patient, they're going to give the home care agencies with good patient outcomes, good satisfaction scores, and low rehospitalization rates. They're going to give those home care companies a little bit more, and the companies who do less well, a little bit less. So it's supposed to be budget neutral, but that's really the long-term plan. Follow the money. And then there's a system called bundling and partnering. So I mentioned that Mike and I met a couple of years ago about Syracuse orthopedic specialists. So those orthopedic doctors are in a pilot program, and CMS wants to see what's the most cost-effective way for a patient to have a hip and knee replacement. If you think about hip and knee replacement patients, raise your hand if you've treated a patient with a hip or knee replacement. The majority of people have. So it tends to be a younger, older person who's a little bit healthier than, say, the 90-year-old who's had a hip fracture. So they're kind of a cleaner population. So CMS is taking the data from SOS and North Country Orthopedics and I think 7 or 11 different physician groups, orthopedic physician groups, have volunteered to be part of this pilot program. And they're looking to see how quickly can you get a patient from the day of surgery to 90 days out. How much did it cost? Did you utilize skilled nursing rehab? Did you utilize home care at all? We're seeing the trends. This is a very progressive orthopedic group here, that some of these patients don't even need a home care episode, which is a good thing. So we want them to bypass home health, but it's probably more appropriate to have home health for a patient who's like a little bit older and who has had a hip and knee replacement. So these are just changes that I've seen probably in the last 3 to 5 years. Big changes in home health. Any questions about that? Yeah. No? Oh, fixing your hair. A question? Yes.
More of an observation. My dad just had both his hips done. There's a tremendous amount of pressure not to get.
Okay, so comment from the audience here was a participant here said that his dad has had hip replacement, both hips replacement, and there was a lot of pressure from the physician to not seek services, i.e. home care.
And we had to really push to say, no, he needs it.
Mm-hmm.
So I think it's on us too to also help the patient advocate for themselves for acute care therapists. That there's going to be pressure to push maybe a little bit too fast and too hard through the service line,
mm-hmm.
through the continuity of care. And even so, they would only authorize like 2 weeks of home health.
Mm-hmm. Right.
And then go right to outpatient.
Mm-hmm.
You got to get to outpatient.
There were further comments from I'm speaking to the people who are connecting by WebEx. So further comments about how as PTs and family members, we need to advocate for getting the right amount of care. And HCR's motto has always been provide the right amount of care to the right patient at the right time. That's all. And then if you do those things ethically and with good conscience and have, treat the patients with respect, you'll be successful as a business. So absolutely. We've seen that too. There's such a dichotomy. Rochester is only, 75 miles away from here? There are physicians there, and I'm not bad-mouthing anybody. It's just the paradigm hasn't shifted over there, who still want 4 and 6 weeks of home care. And we're like, what's up? We're doing, we're not even entering a nurse into a home care episode with folks in this region in Onondaga who've had a hip or knee replacement surgery because the wound is, it's covered by a perioperative dressing and there's little drainage. So it's a very progressive group and it changes even, we set up protocols with physicians so that we can attach them to the medical record. Our electronic medical record is on smartphones. So when a patient has a hip replacement from IZANT, the clinician, the PT can open up that protocol and see right where it is, or right what it is without needing to call the doctor, what's the weight bearing status, that kind of thing. But the progression, they're changing it by the time, it takes us 3 days to get that protocol in there, and they've already changed it because they found something new and better and evidence-based. Fascinating. Question in the back? So you're talking about prehab, like prehab, or preparing for that? Mike could probably speak to that more. Do you want to come up and talk, Mike?
No, but actually prehab is something that, when you talk about the pilot program, it's really, I think for the first of the year, Medicare changed this from a pilot program to including all joint replacements as part of an overall program that they're closely monitoring as part of the development of CEUs. And prehab is something that I know, and this is one of the things when Judy and I sat on a committee, we talked about was the education piece before is probably just as about important as the prehab. And I know that was something that we were looking at. I think the idea we were looking at was 3 to 4 visits of prehab, in-home inspection, so setting it up beforehand so that the expectations are there. And then I'll just speak to the point about, being, if I may, I'm sorry, I should have come up there.
So, speaking to the point also, where we were talking about being advocates, that really comes down to our documentation as clinicians in whichever setting we're in. That's really where our proof needs to be, particularly for Medicare, because understand you can yell, stomp, scream, and jump up and down and say they need home care, but if you're not justifying what the skilled need for home care is in your documentation, Medicare is going to review that on the back end and say, this wasn't justified, this wasn't needed in nature, and they're just going to go ahead and deny it anyway. So, yeah, that's...
Okay. So,
sorry.
Mike gave a lot of information about prehab and how the model is moving from a pilot program to a bona fide. It's not even a pilot. It's just been so successful at reducing the costs associated with joint replacement. So I know we've got a lot to cover, and I'm okay with stopping along the way. I've got some places where I can kind of speed up a little bit. So home care, so the home health episode, so how is the agency reimbursed? During that OASIS assessment, they look at 3 areas in particular: clinical, functional, and service or therapy utilization. So just briefly some what falls underneath the clinical domain. So that's the diagnosis. Do they have wounds? Do they have a vision impairment? Do they have shortness of breath with activity or at rest? Are they incontinent of bowel or bladder? And do they have some behavioral, psychiatric, or depression concerns? Under the functional domain, again, this is really where therapists really can contribute to that overall OASIS assessment. And it's not just like, are they independent, modified independent, contact guard. That's not how the OASIS verbiage is. It's pretty complex. There are certifications in being an OASIS expert in home care. But it's basically dressing, mobility, toileting, transferring, fed mobility, and their ability to manage their medications, injectable medications. And then lastly is the service domain. So this is actually directly tied to therapy. So there's there's additional funds. Medicare sees value in therapy and improving a patient's functional mobility. So they see value in it, and therefore they reimburse home care agencies who provide an appropriate, medically necessary, skilled, with all the documentation tied up, and we'll talk about what part of that documentation needs to include. Medicare sees value in that. And there's a kind of a bump when there's 6 or more therapy visits. It used to be 3 years ago. It used to be 10 if you had 10 or more, or 9 or less. So CMS, this OASIS document keeps changing because they're trying to reduce, the reimbursement for home care, as CMS is trying to do in a lot of venues. So for a patient with Medicare, we have to establish a prior level of function. It has to be very clear. Before their knee replacement surgery, they were driving, going to work part-time in the library. They were, walking up and down the stairs to the basement carrying their laundry. You have to demonstrate what their prior level of function was. We have to perform a functional test. Now, we're not talking randomized controlled trials, because we're going to do a functional test here, and as a home care therapist, you kind of have to do with what's in the home. But again, it has to be you have to be able to perform that test again in 30 days or less to demonstrate to CMS, to the payer, that yes, the patient's improved because of my skilled medically necessary care, and so I'm going to continue. Because if the patient doesn't get better, then you have to stop, consult with a physician, or discharge the patient. And again, there's lots of opportunities for home care agencies not to get reimbursed. So again, we talked about prior level of function. Were they driving? What were they doing beforehand? And again, this is about, this is the elements of practice, to get optimal outcomes. You examine the patient. You do an evaluation. So you take that data and you compile it together and you make an assessment, or you determine what's their prognosis, what's the likelihood of them getting better. Then you provide the interventions, and then you look at the outcomes. You test them again and see, did they do better? And then you examine, you take that data together and figure out, is what I did clinically warranted for me to continue? I mean, this is CMS mandates us to do this as of about 2012. I think they mandated the Medicare therapy reassessment in home care, but we should have been doing it anyway. In fact, a lot of home care agencies were doing it. But now it's required, because if you miss that 30 days, if you don't demonstrate improvement, keep going, there's opportunity for it for you to not get paid for the whole episode. So just an aside, I won't spend a lot of time on this, but to help reduce rehospitalizations, there's this thing called telehealth. People have heard about what telehealth is. Telehealth is it can be anything where health information is transmitted from the patient's home to a physician. So we have telehealth units that we deploy to a patient's home. We teach the patient how to do it. If the patient has struggles with it, we get a PT out there to help them, because they have to step up on a scale. It talks them through gathering data like weight, blood pressure, pulse oximetry. It can do BGs, like blood glucose tests. But it's a way to get, it's another touch point which a home care agency, so this information just doesn't go to the doctor first. It comes to our home care agency. We have registered nurses who look at that and call the patient the first time that they use it, and then periodically, and then whenever their vital statistics are out of parameters. But it's a low-cost way of having another touch point with the patient and keeping them out of the hospital, and some other things. So just a little comic break here. What do you think the greatest risk to a home care clinician, whether it's a therapist or even a home health aide? Any ideas? Dogs? Cats? Cigarettes, right? It's really cat. Typically, it's been needle sticks. So you think about a patient with diabetes, they've done their insulin injection, and, they maybe didn't get out of bed when they did it. They tested their BGs, gave themselves their injectable medication. You as a home care therapist come in and you're working on bed mobility and get stuck. That used to be a bigger one. There's a lot of precautions and education that goes on with home care clinicians about how to avoid that. But really, it's cat scratch. I had a colleague who had cat scratch fever, which I just thought was an old song, but she's okay. So what do our evaluations look like? Again, we're going to kind of speed through this. So we're going to take vital signs. We're going to test range of motion strength. We're going to do a couple functional tests that we'll talk about as well. We're going to ask about their ADLs and IADLs. People know the difference. So ADLs is the ability to take care of your body. IADLs are like your banking. You're setting your alarm clock in order for you to get up in time for breakfast or for the therapist to come. It's it's things that are not directly associated. It might be laundry or cooking or dishes. OTs are our best friends to help us with a patient with IADL difficulty. And then we're going to test their cognitive status and also do some neurological testing. So lots of times that home care evaluation, whether I'm doing the initial visit, that OASIS visit, that start of care, that involves a lot of other things. But I'm going to walk a patient around their house, see how they do getting in and out of bed, in and out of the shower, up and down stairs, if they can even do that. Some patients can't even get up from a chair. So you really have to be I think it's fun. It's being a sleuth. In fact, somebody said it's like being an NFL quarterback, because you got to use your body to move patients around, but it's really a thinking game. You've got to be able to figure it out. And sometimes you get a script that says evaluate and treat. You get a med list and a script that says help from the physician. So you got to figure out, why did they fall? What's going on? And then there's the family dynamics. The son is home in the middle of the day drinking beer. Lots of dynamics. So then we're looking at cardiopulmonary status, like I said, looking at vital signs and interpreting them, looking at wounds and integumentary system, the social economics or the family dynamics. That's a big piece of it too, because if you have a caring daughter who's there 3 days a week, that's a gift to the big red bow, versus a person who has, lives alone, 18 steps to get up to their second story apartment. He got a wheelchair bump up from the, from a wheelchair company to get to their apartment, and there they are. It's different every day. It's a good thing. And then we also take a look at their home environment. What's their lighting like? Do they have an alert system should they fall and be unable to get up from the floor? Are there electrical hazards? You just kind of look at the whole picture. So we're going to look at a couple of exams, and we probably won't have time for the last one there, the gait speed, but if we do, we can. So we're going to start. Are anybody familiar with any of these functional tests? I see some heads nodding, some raised hands. Okay. So the first one we're going to look at is the 30-second sit to stand. I won't make you do it, but it's fun. So basically, it measures a patient's strength and endurance and also their ability to transfer. So what they're going to do is you're going to have them sit in a chair without arms. I'll tell you, probably only about 5% of home care patients can really rise from a seated position without using their arms. But they should be able to because, gosh, the day you can't get out of a chair, you're done, right? Because then you can't get up to go to the bathroom. You're probably heading down this road to nursing home or skilled nursing facility, something like that. So it really doesn't take very long to administer it all. And then the only equipment that's required is a chair and a stopwatch. So a lot of people use their smartphones. But basically, you have a patient sit in a chair and you just say, when I say go, I want you to stand up and sit down as many times as you can in 30 seconds. It's okay if they need to use their arms, but I'm going to document that they needed to use their arms. And that's a functional test. Again, we're not doing randomized controlled studies. We're finding out what's the patient's today, what's their functional status. And like I said, some people can't rise from a chair or from a bed without using their hands. So a score in this test of 0 is valid because that shows. So then if I go back, I provide I go 3 times a week for the first week, 2 times a week for the next week, they're getting stronger. And then I do this test again and they can do 2. That 2 is better than 1. So I've demonstrated that the patients got, become stronger in a functional capacity because of my therapy intervention. Okay, so here are some norms for ages and male or female. You can see in that I've seen a couple of patients over 100 years old who can do 5 or 6. But again, there is really the outliers, but we don't have any normative data for people over the age of 95. Okay, functional reach. Has anybody heard about this test? Familiar with it? This is a good test. OTs tend to like this one too. So this, again, the purpose is to see how far a patient can reach forward without losing their balance. It takes just a couple of minutes or less to do. And all you need is a yardstick. I use, we have paper tape, but you can use, one of those, if you go to a, national conference or something, they give you the tape that retracts. I use that, and then a piece of tape on the floor. So basically, in some homes, you can't even find a clear space in which to do this. But basically, all you need is a wall. So oftentimes, I'll go to the refrigerator and I'll put a piece of tape on the floor so they see the refrigerator is here. So this is the refrigerator. I'm going to put a piece of tape where my feet are. Then I'm going to ask the patient to raise their arm to 90 degrees, make a fist. So you're going to measure from knuckles. You're going to put that measuring tape out in front. So you're going to measure where they are here, ask them to reach as far as they can without moving their feet or stepping. And while you're doing this, you're not just looking for the measure. You're going to look for, are they using hip strategy first, ankle strategy, or going right to stepping strategy to prevent their fall. So you're going to measure from that baseline of maybe 5 to 7. So if a patient can only reach, a normative value I think is, Fallsworth cutoff is 6 to 7 inches. 10 is relatively good for an older person. So people say, Judy, who cares if somebody can reach? We reach all the time, don't think about it. So if you think about a 90-year-old who's living at home alone, she's got to be able to reach into maybe to change her kitty litter. She's got to hang up her coat. She's got to, reach down to the dishwasher. So it's kind of a static standing measure, and it's pretty easy to replicate. So here's a demonstration. So the instructions are to reach as far forward as you can without taking a step. Keep your feet flat on the floor and keep your hand at the level of the ruler. If you're not, you can't reach along the wall. The thing is about that timed up and go. Did we do timed up and go yet? Not yet. We'll talk about that. This one, you can't really touch anything else. You have to, I guess you could quantify it saying the patient needed to use a walker. But if a patient's using a walker, they can't reach forward without success. So I would bypass this test. You get a couple practice trials so the patient understands it, and then you have the patient reach forward. So now we're going to talk about timed up and go. So the purpose of this is to measure how quickly a patient can rise from a chair, walk 10 feet, turn around, come back. So it looks at their gait speed, but also it talks about that turning, because there's a lot of information you can get with an older person to see how long or what's their approach when they need to turn. Can give you a lot of information. It takes about 3 minutes. All you need is a chair, 10 feet of clear space, which is not always easy to find in home care, and a stopwatch. So can I get my volunteer? We're going to demonstrate it's timed up and go. So I have a seat here, and I don't carry a cone or anything like that. I use my stopwatch. Can somebody be a timer for me? Somebody got a timer? Okay, thanks. So I'm going to look for a remote control, anything that's in the house. I can find a Beanie Baby or something. But you want something that has contrast with a rug. This isn't such a good idea because it's almost the same color as the rug. So, and usually for safety, I'm going to guard you, but I've got this. Okay. So usually I just, you can put even a piece of tape on the floor, but you're going to ask you to stand up and as safely as possible and go as quickly as you can. Stand up, walk to that trash can, and come back. If she needs to use the walker, it's okay. You want to quantify that in your documentation, but that's okay, because if a patient, say, I've had a patient take 5 minutes to do this. She had Parkinson's. It was from a raised seat already. So she was open to home care a couple of successive episodes, but we got her down to about a minute. Do you think that changed her life? You better believe it. And it clearly demonstrated that at the end, she didn't need to use the recliner in a raised position to start. And 2, she had not quite normal gait speed, but gosh, she could get to the bathroom without, she wasn't incontinent. So getting to the bathroom was a goal of hers. So pretty life-altering for her. So do you understand the instructions? Yes. Okay, who's got the watch? Okay, so when I say go, stand up, walk to the can and walk to the basket and turn around and come back. Ready? Okay. Get set, go. Oh, she's going to be a normal person. And stop. So how long? Okay, great. So, athletes can run it. You and I can run. Yeah. Well, you can understand if a person's got Parkinson's or something like that. And you can tell, like maybe once they're up and once they get their balance, their gait speed might get better. So it gives you a little bit more information. I really got to maybe work on her lower extremity and hip strength so that she can rise to a chair. Because once she's up, she's good. And then you can see if people have vestibular or balance trouble, if she really hesitates and really stutter steps or clock steps to turn, and then she's okay on the straightaway. It gives you a little bit of information if you think about it. Thank you. Mm-hmm. So this is probably the most commonly used test in home care. Again, here are some norm values and associated fall risk. So that fall risk is for community dwelling people over 65. So we're really shooting for people who can do that in less than 10 seconds. Okay, 4-meter walk test. We will have time for gait speed. Okay, great. So this is the lowest distance of walking that we can measure, which we want a shorter distance. 4 meters is really pretty long. And then there's, the evidence says that you really should have time for a patient to accelerate and then decelerate. So if you got room, you can do upwards of 10. But basically, takes less than 10 minutes to administer. You just need a stopwatch in a 10-meter pathway without turns. And then there's some information about minimally clinically important difference. And then there's some very interesting predictive validity associated with gait speed, and we'll talk. We've got a great graph about that, about the slower a patient is, really the more apt they are to not return home, to even have some mortality associated with it. I won't demonstrate this, but you can kind of see. You're going to have the patient stand up when you say go. When, if you've got that 10 meters, you're going to mark out the spot in the middle that are 4 meters, and you're going to stop your stopwatch then, because that's the number of meters and divided by the time, or the time divided by the meters. So this is a collection of walking speed times, and they're a correlative information about their discharge disposition from their ability to return home. So if you see right in the middle there, or in the bottom, over toward the right, is 1 meter per second is really a cutoff. 1.2 is kind of the gold standard for home care patients. You really need to walk that'll get you across a street with normal walking speed. I was just at Combined Sections meeting, and it was in Anaheim, huge city. So they had the crosswalks. Everybody waited because in California, the number of pedestrians killed at crosswalks is huge. I only know that because I have some friends who work in acute care hospitals there. Pedestrians getting struck all the time, people turning right on red. And then they're slower. I can't say, maybe they got the California mindset, but they're walking a little slower. I don't know. But I was just thinking about gate speed. You really had hustle to cross these 6-lane highways. And boy, that time was going down. You're like, so anyway. So you can see people who are walking at 0.6 meters per second they're likely to be hospitalized. They are dependent with ADLs and IADLs. They need, and this is again for the group who are WebExing in, look at the middle bar, the need for intervention to reduce fall risk. This is evidence-based. So if you have a patient with less than 1.0 meters per second gait speed, they need physical therapy to improve their gait speed, to improve their overall functional mobility. Okay? So these are functional, a minimal gait speed to cross the street is 0.49 meters per second. And then this is a fascinating facts. In home care 20 years ago when we started, we said we wanted a patient to be able to walk 100 feet with a rolling walker, at least restrictive device. But that is not functional whatsoever. Really, to go to a superstore like a Sam's Club, Costco, BJ's, wholesale club, you need to be able to walk 1,900 feet. So, and there's their correlation in meters. So you really, even to go to the bank, and those are functional things for a senior to be able to do, they have to have good endurance, quite frankly. So measuring like a 6-minute walk test might be something if your patient has relatively good gait speed, but they're short of breath with just doing it maybe a timed up and go. You might want to do an alternate test that gives you information about are they going to be able to return to be a community ambulator. Again, home care PT goals. So now we've done the home assessment, we've done maybe that OASIS assessment to establish the care plan. So now we need to come up with our PT goals. Again, like any other therapy goals, it has to be measurable, functional, achievable, and you have to have the patient's participation and agreement to achieve those goals. So I don't know if anybody's read the book on motivational interviewing for the healthcare provider. It's a great book about how to understand or how to elicit patients' goals to get their buy-in so that so that they are more likely to actively participate in their care plan. Because if I just want them to walk 500 feet, that might not mean anything. But if I drill down and be patient and wait for the response, the patient might want to be able to walk to their daughter's wedding in June. So that means more to them than walking 500 feet. So typical home care goals, this is kind of it in a nutshell. And again, these are related to some of the tests that we took. So patient will perform 8 chair rises in 30 seconds to reduce fall risk and allow the patient to transfer without assistance into and out of their family sedan. So you have to make it functional. But I took that, maybe a 30-second chair rise test and embedded it here. I didn't need to state what the previous score was, but I can look at that when I do that Medicare reassessment at day 30 or on or before day 30. A patient will have a gait speed of 1 meter per second or faster with least restrictive device to permit safe ambulation in the home and reduce the burden of care on the caregiver. And then another example might be a patient will safely reach 10 inches or greater to permit her to safely turn on the water from her tub and shower faucet without loss of balance or a fall. Does that make sense? You're still awake. So our interventions, we talked about, we've done the assessment, we looked at the home, we've developed some goals. What are our interventions? So we do not have an outpatient home care clinic or an outpatient clinic in the patient's home. We oftentimes use, graded repeat sit to stand instead of, we don't have, we don't have a nice electric plinth. So we might work from that recliner that's raised up a little bit and measure how, or it's up about halfway might be where we're training, and then lower it over time. Or we might even start with a patient sitting at the edge of the side of the couch where it's a lot higher, like the armrest on the couch, to work on repeat sit to stands, because if they can't get up from the normal level of the couch. You got to figure out a way to get them to a higher place to train. But again, you can work on pretty much anything in the home. You just have to think about how can they move their body. Is there weights that I can find in the home, pennies rolled up in the socks, soup cans. You can really be pretty ingenious in home, and I think that's what sometimes is attractive to home care attracts therapists to home care, because you really have to be pretty innovative to find out ways to get a patient stronger and faster, like the Bionic Man, in a home setting where you don't have a lot of equipment or any equipment. TheraBand is pretty prevalently used in home care. People have used TheraBand, TheraTubes. Some modalities we can use: heat and cold, electric stim. Most home care agencies have like a unit that they can borrow, ultrasound unit or eStim. We do some wound care, mostly dressing changes associated with joint replacement, surgical wounds. We do work on pain management, so using your manual techniques, joint mobilizations, positioning, patient education. Then also breathing techniques like pursed lip breathing, or teaching a patient, helping them figure out if they have asthma or COPD, when's a good time of day to exercise indoors or out, based on the humidity, based on the rain or the snow, that kind of thing. And then also falls risk reduction is a big piece of what home care. I think almost most all patients in home care are at some sort of fall risk. Again, it all comes back to this, where we evaluate the patient, we examine the patient, we evaluate the data from the tests that we took. We come up with a prognosis. Do we think the patient's going to get better based on our clinical expertise? We provide the intervention, the care that's based to make to achieve their goals. We look to see what their goal, have they met their goals by re-examining them, and then we make a decision. Is the patient getting better because of our intervention? So in review, home health is growing, but it's a small but a growing sector of healthcare. It's highly regulated. It has lots of newer benchmarks. It requires a holistic approach. So you're not just looking at the elbow. You're not just looking at the knee. You're looking at who do they live with? What are the physical barriers in the house? What are the socioeconomic pieces? Do they have any equipment that you can use? So you really have to put your head around all pieces of the patient's presentation in their home. And then it's all about function, function, function. Any questions? Yes?
How many patients are you able to see in a day? Call ahead if doing well? Is that a big barrier?
Yep, that's a good question. So the question was about how many patients do you see a day, and are there barriers? What was the second part of the question?
Just to make sure they're willing.
Oh, do you call ahead to? Yeah. Quite frankly, there's a lot of variability in that. How I practice is I would definitely call the night before and tell them I'll be there in the early afternoon. Because if you say 2 o'clock, they're calling the office saying, "Where's Judy? She said she'd be here at 2 o'clock." You have to give them a ballpark and just say, you know what? This year we got traffic, we got snow, we got construction, we got school buses, we got bridges out. When you establish, you establish the rapport in your first couple of visits, and then they eventually get it. Just give me a little latitude. And if I'm more than a half hour late, I'll call you. So we've all got smartphones, and if you think about the Syracuse area, we've got good connectivity. But you think of Plattsburgh and the Adirondack Mountains, there are parts of that region that there is no cell phone signal, no Wi-Fi, no nothing. So that's probably one of the bigger barriers. But definitely calling a patient ahead, that's up to the individual clinician. Most clinicians set it up the evening before or the previous visit. If you got a patient who's cognitively intact, you can say, it's today's Wednesday, I'm going to come back next Monday early afternoon, 1 to 2 o'clock. And you can write it down on their calendar or whatnot. The question about how many visits a day. Now, we have 3 full-time PTs in our Jefferson County office, so that's Watertown. They can't see 5 and 6 a day like we ask the folks who are living and working here in Syracuse. Do you live in a city? You can see 6 and 7 patients a day because you don't have that travel between. So it really is dependent on your physical geographic region. That's a great question. Thank you. Yeah.
What's, I guess in your agency specifically, what is the role of PT as far as the patient's medications go, reconciliation, things along those lines?
Okay, so the question was, what's the PT's role in home care as far as medications? So our Practice Act is very clear about medication management. The PT can do what's called medication reconciliation. So that means the shoebox comes out on the table, and I got the list from the hospital or from the physician, and I match to see, yep, lisinopril 20 milligrams twice a day. Metformin, 1 pill, 20 milligrams, 3 times a day. I can confirm or deny that the patient's taking those medications. That's it. In our electronic medical record, it gives us warnings when there's a drug-to-drug interaction or a possible adverse drug, a drug possible, interaction problem. Once I synchronize that data to the server, it's called workflow, but it signals a registered nurse to look at it, and so she can look at it, and she'll call a patient because that's in her scope of practice, and then she'll confirm with the physician about if she thinks you need changes, like if they're on a low-dose aspirin and a Coumadin. That's a direct contraindication. I know that, but I cannot educate the patient on that. It's out of my scope of practice. Yes?
I work for the VA, so not as concerned with the Medicare stuff. One of your services mentioned for a guy that coming to the end of his term of home that they were going to consider him on the maintenance protocol. Is that something that Medicare is now allowing?
Yes. So the question was, what's the role of maintenance therapy in home care? It's actually since the Gymno and syllabus, there was a patient took CMS basically to court and said, under my provider manual, it says that I'm eligible for a home PT or home restorative maintenance therapy. It says it right here in the benefit manual. And basically the patient in that advocacy group won. So yes, maintenance, there's lots of parameters. That's a whole nother discussion. But yes, patients with Medicare and Medicare Advantage insurance companies are eligible for home care on a long-term basis for maintenance. There's criteria like they have to still meet the home care criteria. They have to be homebound. It has to be medically necessary. But the goals aren't to get better. The goals are to remain at that level, because without my skilled intervention to stretch the patient or to do whatever, the patient's likely to have an exacerbation and be rehospitalized.
What you usually do is if you think they need that, we don't do a lot of treatment, so that's what for you guys. And usually we'll write kind of a prescription doctor sign off on.
Mm-hmm.
Is that something where we specify at that point if maintenance versus restorative?
Well, so the question is, you're working the VA system, so there's a caveat in that you can only bill one federal payer at a time. So it's either VA in what you do, or it's a home care episode. It really has to be one or the other. One entity won't get paid. So VA tends to be the chronic management. We'd love to be able to provide that care, but can't. It's all about the money. Yes?
Yeah, just a comment for information on the gym.
I know how you talk, Mike.
No, I'm sorry.
For anyone looking for information on Gymno Syllabus, which was really just a reiteration of what the actual Medicare guidelines were, it's actually Medicare, part of that lawsuit, had to provide informational resources to providers on their website. So if you go to cms.com, there's a big MedLearn Matters actually PowerPoint on there that goes through the decision and why the decision was what it was and what constitutes maintenance therapy and what you need to do to go through it.
Right, and actually there's another lawsuit because in the settlement, Medicare said that they would be providing education to providers. They gave one session. So most people don't know what it's all about. Oh, okay. Click the talk bubble. One more. Chat. Here we go. Does Medicare recognize and reimburse for skilled interventions provided by PTAs? Yes, Medicare does. There's the 30, not in a maintenance situation. CMS is very clear about that. But yes, there's still a rule of the 30 days. So, and in New York State, if we're talking New York State, the first visit has to be PTA and PT, not necessarily at the evaluation, but the PTA has to be there with the PT in the home at the same time to discuss the care plan, and the PT has to determine if the patient is appropriate to be seen by a PTA. And then every 30 days, the PT has to be back in the home to reassess the patient. But yes, I worked as a PTA in home care. Jennifer and I were talking about that earlier. Some insurance companies are not reimbursing for PTA, CODA, or LPN care, workman's comp, the no faults, and they're just trying to squeeze the PTA out of the home care setting and the whole maintenance thing. None of the care provided in a maintenance situation can be provided by PTA. Does it make sense? Good question. Oh, one more?
Yeah, I just had a question about if possible issues with privacy with the is that a specific
Okay. So the question, I had alluded that we do our electronic medical record. Our documentation is done on a smartphone or a tablet. Yes, it's HIPAA encrypted. So you see that I had to put in my password here. I was on another program. So we have HIPAA encrypted email, so I can email you about my care plan. If you're the subsequent therapist, I can write, hey, Jennifer, saw this guy, he's in your territory 3 times a week. Here's the patient record. So it's all HIPAA encrypted. If I'm at McDonald's, stop for a cup of coffee and a bathroom break, and I turn my head and my phone is gone, I call our IT department, and they'll have that back to factory settings in minutes. HIPAA is a huge thing. But, you know, electronic medical records have kept up with it. That's a great question. Yes? Okay, so that's another good question. Does a patient have to be hospitalized to qualify for a home care episode? No. So as long as they are homebound, it's difficult and taxing for them to leave their home, and they're Medicare eligible. All those other conditions of participation, yes, they can. I would say probably about 30% of our patients come directly from an assisted living facility. So an administrator has seen that their resident has fallen. They went to the ED. They're okay, but now they're afraid of falling. We can help keep that patient, we can begin an episode there, get that patient rehabbed, address their pain, keep their resident in that bed. We partner a lot with assisted living facilities. But no, they don't have that 3-day qualifying stay that SNFs need or short-term rehabs need. Other payers generally pay for home care as well without the 3-day hospital stay or even a hospital stay. In fact, I've treated a long-standing woman who lived around the corner from where I live. I see her husband out and walk. She'll say, oh, his wife is pretty debilitated, and she routinely comes back on. Our company makes it relatively simple for a home care referral to happen. So the patient or a patient advocate can call our intake department, and we'll send a PT or nurse out there, and if they're not eligible, we won't bill them for the visit, but we'll connect them with the appropriate service. Okay. I think we can wrap it up. But people are going to stay online for the business portion of the meeting? Okay, you're going to turn on. Okay. Well, thank you for your attention and time. It's been really nice to meet with you tonight. Appreciate it.